Well, welcome to the afternoon session. I am Maria Sabornil from Spain, Valladolid, and I met Professor Burnier 1 century ago also, before the lab was established here. And I am running an ocular oncology clinic and related with all the ocular pathology for more than 20 years. And you?
Hi, I'm Rubens Belford. I met Dr. Burnier back in 1976, and I did a fellowship here between 2007 and 2009, and I'm a member of the team of ocular oncology at the Federal University of São Paulo in Brazil. I did a fellowship with Noralia also. And well, thanks to Dr. Burnier and especially Dr. Rum Singh, I've had the pleasure to help, and now I'm the president of the Pan American Ocular Oncology Society since February this year.
That was Dr. Rum Singh before, now is Dr. Rubens Belford.
Thank you.
Okay, and now we're moving on, and the first paper presented in the session is by Rafael Galli about the review of frontal sinus fractures.
Good afternoon, ladies and gentlemen. I'm very happy today to present the review of frontal sinus fractures at the Montreal General Hospital, MGH, McGill Level 1 Trauma Center experience with a special focus on the eye. I'm doing a craniofacial fellowship here at McGill with Dr. Lucy Lessard, the Division of Plastic Surgery. I have no disclosures. Facial and frontal fractures are the result of high-impact trauma, motor vehicle accidents, and sport injuries. They can involve the anterior table of the frontal sinus or the posterior table or even both. Despite all the prevention being done since last years, facial trauma and trauma itself has been rising progressively, as you can see in this diagram. We had between 1994 and 2009 over 22,000 trauma cases and almost 3,000 facial trauma, demonstrating a large experience, one of the largest experience in this subject. We've been with great interest in delayed repair of this kind of injuries. And so it's very important to understand this kind of fractures, the frontal bone fractures, the G-force concept. If you have the anterior table and the posterior table of the frontal sinus are very thick and need a high impact to get fractured, almost 200 G-force to have this bone fractured. If you have it, you probably will have also associated other injuries. The other bones of the facial skeleton are weaker, and they are most likely to be fractured as well. So, if you have a fracture of the frontal sinus bone, you probably will have a high effect on the globe, the eye, and also the brain, the closest structures in this region. So, to get a thorough understanding of this, we did a systematic review of the frontal bone fractures at the Montreal General Hospital, Level 1 McGill Trauma Center. Data was collected from electronic medical records from all adult patients presented at the emergency department of the MGH since 2008 to 2014. A total of 21 variables database was collected, and to name a few of them, demographics, mechanism of trauma, fracture type, associated facial injuries, treatment, and its complications were reviewed, carefully reviewed. So we found 288 frontal fractures and 3,653 facial fractures. And we also could observe that this number is rising. The black bar is the facial fractures, and the blue one, the frontal fractures that are progressively increasing also. Right? Okay. So between the 140 patients that met the inclusion criteria, we had 90% of them being male, and a very interesting pattern of young men of 40 years old. Regarding the distribution of the trauma etiologies, we had motor vehicle accidents, closed followed by severe falls with equally almost 40% each. You can see here in gray and yellow. Following that, 22% of blunt injury, and very interestingly was, and funnily, as people keep saying that interpersonal violence is increasing in Montreal, and it's hardly for a Brazilian to say that, we had only 4% of gunshot and sharp injury. Regarding the fracture pattern, isolated anterior table in almost 1/3 of our cases, 8% with isolated posterior table, and almost 2/3 of anterior and posterior table fractures. Very interesting were the associated fractures that we encountered in this series. Because of this G-force that I told you, we had 80% of associated orbital fractures, followed by 66% of maxillary and 64% of nasal fractures. It's mandatory to clear the spine before any surgery. So we had 16% of C-spine injury, demonstrating also the high morbidity of these lesions. But what mostly popped out our data was almost 30% of ocular injuries. We encountered 39 trauma-related ophthalmopathologies in our series. The most frequent ones were optic neuropathy, ptosis, orbital hematoma, followed by subconjunctival hemorrhage, mydriasis, exotropia, gaze limitation, and the muscle rectus entrapment. So we divided these lesions in extraocular and intraocular injuries. The extraocular mechanical, we had 39% of mechanical causes, 6% in green from cranial nerve palsy, most likely the third, the fourth, and the sixth nerve. Regarding the intraocular causes, direct globe injuries in almost 33% of the cases, optic nerve injury in 20% of them. And we had one case of blindness after the trauma. Regarding the treatment, we have several factors to decide which kind of approach we will have to these patients. Fracture type, degree of posterior table fracture, nasal frontal duct injury, neurological status, concomitant head trauma, presence of CSF leak, and retinal detachment. It's very important to highlight that we could safely delay our treatment in behalf of associated injuries like the retinal detachment. Dr. Lessard published this delay repair that is mostly, we use different strategies to reconstruct the orbit after a long time of the trauma. We use like only bone grafts, redoing osteotomies, and complex reconstructions. And we could demonstrate that there were no major sequelae, no major problems with the patients. It's safe. So as I pointed in the beginning, the G-force is very important to see the structures in the eye affected and these ocular injuries. Sir Samuel Ernest Whitnall, a great ophthalmologist at McGill at the last century, gave a huge contribution to this knowledge. So I would ask you, would be the Whitnall ligament and its structure enough to protect the eye? Due to the intimate association of the frontal bone fractures and the brain, the orbit, and the eye in high-impact trauma, these fractures rarely occur isolated. It's mandatory to have a thorough examination, ophthalmic examination to the patient at the moment of the trauma, to give a close follow-up and promptly identify any ocular injury, to have the treatment immediate if necessary, to prevent any further sequelae. So we interestingly found 29% of ocular injuries in our series, and comparing with the literature with 15%. Why is that? Is it because of our severe cases of MVA causes the etiology that's very high impact and severe falls that can lead to this higher number? or would it be because of the prevention that's being done, like the airbag? You all know that there's a highly association with airbag injuries and ocular injuries as well. Or would it be because the ophthalmologists of McGill are better than the others, and they could diagnose more these lesions and take better care of our patients? Fortunately, the residual complications of this kind of injuries are very low. In conclusion, the prompt diagnosis and the proper management is paramount to have less complications, short and long term, of these potential devastation lesions. It's very important also for the clinician that take care of these patients to be aware of associated injuries, mainly regarding to the C-spine, to the globe, and to the orbit, to get even better outcomes. So for the future in prevention, we should look closely to these injuries and how we could decrease this number of 29%. We look forward to do a study on ocular injuries and groups of MVA and falls. I would like to thank you very much, my supervisor, Dr. Lucy Lessard, the Chief of Plastic Surgery here at McGill, all the Division of Plastic Surgery, the residents, Alex Vizet, that's the resident for the second year and contributed directly for this work, and of course, Dr. Miguel Burnier for the invitation for this presentation. Thank you very much, and I'm here to answer any questions that you may have.
Any questions or comments?
What is the incidence of gunshot wounds in Miami, for example? When you compare Montreal to North America, compare Canada to United States, certainly those numbers are not American numbers in certain regions in the United States, right, where guns are much more readily available than with us.
For sure.
The comparison is, that's what it is? We have much more car accidents and they have much more gunshots?
Yes, for sure. The gunshot accidents, the interpersonal violence is much less here. And of course of guns with also.
2025. Where is Maria Eugenia? Maria Eugenia is from Caracas. A lot. I thought it was a very interesting communication, and I would like to thank you very much for joining us and being here. I'd like to say one thing about Lucy Lessard. She's a great friend, a fantastic surgeon, does a phenomenal job at McGill, and is very well recognized internationally, particularly where? In Brazil, where she has been visiting on several occasions, been invited to several conferences, and I'd like to express my gratitude that you brought your team here. It's a great pleasure. Thank you.
Thank you very much. It is my honor to invite Dr. Julia Burnier, and she's going to be speaking on correlative studies in clinical trials. Thank you, Julie, for attending this meeting.
So good afternoon. Thank you for having me here. I'd like to thank the organizers, Dr. Bernier, better known to me as Papai. It's been really a great pleasure in the last 2 days to see so many people that I grew up seeing, people that are friends, that I respect as scientists and clinicians. The moderators here today, Dr. Belford is actually, to me, Booby, and he's essentially my brother. And Dr. Sauernil was my Spanish mother when I was living in Spain doing my postdoc, so I'm very grateful. Thank you. So I'm going to change the pace a little bit. I'm not an ophthalmologist. I'm a basic scientist. I work at the Princess Margaret Cancer Center in Toronto. And my role there is in the clinical trials program. I actually focus on gynecological malignancies, not uveal melanoma, but there we focus on looking at clinical trials not only from the perspective of efficacy and safety of investigational drugs, but also looking at how we can understand the biology of the disease through the tissue that we obtain. So for those who aren't familiar with Toronto, with the center there, it's a very large clinical research center. We focus on basic translational and clinical research, and we have more than 100 new clinical trials every year at Princess Margaret, and close to 300 trials underway at any given time. In fact, 1 in 5 patients that's treated at Princess Margaret will go on at some point to a clinical trial. Some numbers of accrual. Last year alone, we have close to 9,000 patients on some sort of clinical study, and more than 2,000 on clinical trials. So this has been increasing year to year, and this is a huge amount of resource in terms of patient tissue so that we can study these diseases. This is a little bit of a snapshot of what a basic patient would undergo. Each patient is different, as we all know, but just to give an idea of the type of tissue that we obtain and the type of treatment that they may undergo, a patient may be diagnosed and undergo some sort of debulking surgery or resection, which we call archival tissue. They may have their first-line treatment. If they relapse, maybe have a biopsy then, a second-line treatment, and so forth. At some point during their treatment, like I said, 1 in 5 patients may be offered a clinical trial that may help their chances of recovery, and we draw blood throughout this treatment paradigm. During the clinical trials, each clinical trial is different, but we write into our protocols various tissue draws. So that can be things like biopsies, serial biopsies throughout treatment, before treatment, on treatment, and after treatment, as well as blood draws throughout. And as our trials grow in complexity, so do the questions, the basic science questions that we ask through them. And some of the things that we ask in the correlative sciences program is how we can understand the biology of the disease and response to treatment using the tissue that we obtain in clinical trials. Another really important part is determining perhaps patient subgroups that benefit from disease, and this can be patients with a specific genomic profile or patients with specific immunohistochemical markers that may be more prone to having a positive or negative response to specific treatments. And of course, validating and discovering novel biomarkers that can help us understand response and resistance to disease. Here on the right, I'm showing last year we obtained almost 20,000 tissue specimens just from our clinical research program. And this is peripheral blood mononuclear cells, urine, plasma, serum, blood, biopsies, and archival tissue. So with this abundance of tissue, what can we do with it? Immunohistochemistry remains a hallmark of what we do, looking at biomarkers, and this can be specific tumor biomarkers such as P53, as well as epithelial mesenchymal markers, Ki67, apoptosis, angiogenic markers. We have a huge focus on genomics. Most of our trials now have some sort of genomics component to them. And that can be things like targeted sequencing using panels. So if we know that there are specific mutations in a specific malignancy, we look at that. Sometimes we have a more investigational approach where we're looking at whole exome sequencing or whole genome sequencing to try to understand how that particular patient may do on a trial, so the idea of more personalized medicine. We have become acquainted with proteomic methods now that we use in our clinical trials, immune profiling, and liquid biopsies. And I wanted to elaborate a little bit on liquid biopsies. So what are liquid biopsies? Probably most of you are familiar with them, but there's 2 main types: circulating tumor cells and circulating tumor DNA. Circulating tumor cells are exactly that, circulating tumor cells found in the blood. And circulating tumor DNA are small fragments, 100 to 200 base pairs of DNA that can be isolated in blood. They are complementary methods. They, for a long time, were thought to be competing methods, but they actually have things that they each offer. CTCs are isolated based on their size. As we all know, tumor cells tend to be larger than non-tumor cells, larger nuclei. They also express certain epithelial or mesenchymal markers depending on the malignancy, and that can be used to isolate them. They are used to monitor disease burden, and in fact, we found that elevated levels of circulating tumor cells are a marker of poor prognosis in various malignancies. ctDNA is a more recent hot topic, but actually ctDNA was first isolated in non-patients, just regular people, in the 1940s, And it was later found in patients, tumor patients in the 1970s. And basically, it's based on the isolation of known mutations. So if you know that a patient has a particular mutation, you can target that mutation and try to find circulating tumor DNA in their blood. So the obvious reason for that is that biopsies aren't always possible. And if we can use blood draws instead of biopsies to help understand a particular patient's disease course, that's incredibly valuable. What's interesting about circulating tumor DNA in particular is that it's an average snapshot of that patient's disease at that moment. So when you biopsy, as a lot of people here do, for example, a liver metastasis, you're having a snapshot of that tumor in a very heterogeneous environment. So the clones that you see in that particular biopsy may not be representative or may be representative of that tumor. When you look at ctDNA, you're getting an average view for that patient. So it's a more systemic view of that patient's disease. So one example of this, one application of this that we use in our gynae clinic is that more than 95% of patients with high-grade serous ovarian cancer, which is the histology that we most commonly see, have a mutation in TP53. And there's a varying association between IHC for P53 and TP53 sequencing. I think it's already been mentioned a few times, the P53 IHC here, but for those that do that routinely, it really is dependent on the pathologist's eye. And seeing P53 positive, negative, overexpressed, wild type is not always concordant with what is actually going on in the genomics of that patient. And pathologists disagree, and there's a lot of variance between reads. So it's not the best way to determine whether a patient is truly TP53 mutant. TP53 specific sequences have been found in the blood and the peritoneal fluid of women with epithelial ovarian cancer, and mutations in P53 have been found to be a sensitive indicator of the presence of ctDNA and may be associated with prognosis. And this is a figure from a recent study in PLOS ONE in 2016 that showed that, in fact, ctDNA, this is a small cohort of about 40 women with epithelial ovarian cancer, high-grade serous, that ctDNA was actually a better predictor of relapse than CA125 levels, which is our gold standard in gynecological cancers and ovarian cancer, and actually detected reoccurrence with more than 6 months time frame before radiological relapse could be determined. So that was quite interesting because 6 months is a long time. It's a long time to intervene and to do something for that particular patient. So I wanted to bring it back to uveal melanoma. So this is actually quite a hot topic right now in uveal melanoma, the idea of ctDNA. More than 80% of uveal melanoma express mutations in one of two paralog proto-oncogenes, GNAC and GNA11, which are part of the MEK-ERK signaling pathway and are therefore potential targets for drug therapy. And a prospective study in 2014 in the International Journal of Cancer analyzed CTCs and ctDNA in about 40 patients with uveal melanoma. And they found CTCs in some patients, but interestingly, they found ctDNA using these two mutations in 86% of patients that they knew had that particular mutation. And that really shows that blood, in these cases, are essentially enough. You wouldn't have needed the biopsy, for example, in that case, to detect these mutations. And the paper later showed that the CTC count and the level of ctDNA was actually associated with the presence and volume of metastasis, as well as progression-free survival and overall survival. So in terms of applications of liquid biopsies, like I've mentioned, serial biopsies are just not always feasible. They can be very painful for the patient. It's not like working with mice where you can do more with. You have to take into account how feasible it is. And an example perhaps in your clinics is patients with 20/20 vision, that a biopsy is just not really an option. Sometimes you don't actually know the exact location of the tumor, or the tumor may be difficult to sample. Another application is in trying to determine early relapse, predicting progression. For example, most people here know that uveal melanoma, once you've had a metastasis to the liver, the prognosis is quite poor. If you're able to actually predict that relapse without having to do biopsies ahead of time, it changes the way that we can treat patients. Monitoring genomics changes over time is quite important, especially in tumors that can change rapidly and can change aggressively to a more aggressive phenotype. And ultimately, I think the goal here is to try to modify treatment according to molecular changes, the idea of personalized medicine, and to try to truly target that particular patient's tumor versus target a malignancy in general. So to summarize, clinical trials in Toronto and in Montreal as well are becoming increasingly important as new drugs are developed, especially targeted treatments. Using correlative sciences to understand and target treatment is essential, alongside seeing efficacy and safety in clinical trials. The collection of tissue is becoming much more complex with advancements in technology, and I believe liquid biopsies are a very promising tool to study tumor biology and clinical course. And this is my last picture from the lab a few years ago. Thank you very much. Questions?
Thank you for excellent overview, because I'll touch upon this on my next section.
Oh, good.
So what I want to ask you was, you mentioned the numbers, 20,000, 30,000 patients, etc. What is the percentage uptake from eligible patient to enrolled patient? Say you have 100 eligible patients for a trial, how many % actually convert or enroll into a trial?
Go and end up going. I think it varies quite a lot of malignancies, so I can only really talk about gynae malignancies, unfortunately. But we have some trials where we might have 5 to 10% that fail screening, and we might have trials that everybody goes on. And that differs a lot based on the criteria to go on trial. So if you have a trial for a rare malignancy where there's not that many options, most people tend to get on the trial. If you have a trial for a very targeted therapy where you may need, for example, to have a specific mutation in something, a specific tumor load, CA125 level, then the criteria are more stringent, so more patients could potentially be first informed of the clinical trial but fail in the screening process. But I'm not sure the numbers, unfortunately.
Is it generally true that there is more burden of testing and travel and retesting and exams and imaging in a trial than outside the trial? And that could be a factor to enrollment or not?
I mean, it probably is. I think you have to keep in mind that when patients who go onto clinical trials, there are cases of patients who go on because that's the best thing for them. But in a lot of cases, there are no other options. So while it may be more burdensome, a lot of patients do see that as an advantage to have something available to them.
Thank you.
Is there any relation to tumor burden and your ability to do your biopsy and find out information that's important?
Definitely. I mean, I think and then that's one of the issues with our biopsies, is that for some of the trials, they're mandatory, some of them they're not. But of course, the state of the patient is going to deem whether that patient's fit to have a biopsy at that particular time, and tumor burden is going to play a role. So a patient with high tumor burden is more likely to be unwell, and is there more likely to not be able to have a biopsy performed on them due to their general state. So it becomes difficult to get biopsies in those occasions. Yeah.
Thanks for your talk. We're just starting. I have a lot of voice, but
For those of you who don't know, this is Dr. Peter Detrakus, who is the director of the cancer program at the new Inuit CRI, and he is with us next door with our uveal melanoma. He was one of Julie's supervisors when Julie did a PhD at McGill. Is that right?
That's right. One of my mentors, too.
thank you, Miguel. We're just starting to sort of try to put a liquid biopsy program together attached to the MUHC Biobank.
Okay.
In Toronto, is there any thought of, there are particular cancers, you know, where you can group it where they become familial, for example. The thing that comes to mind is pancreatic or familial pancreatic cancer. And there are now certain centers, including our own, that are putting together screening clinics. And in terms of volume, in addition to the familial pancreatic cancers, we're putting in, IPMN and mucinous cysts of the pancreas that also have high risk. I'm just wondering if there's any thought in Toronto of using liquid biopsies as a screening tool in those types of sort of scenarios, because screening for pancreatic cancer means that you're going to get an MRI and an EUS and another blood test, and it gets a little bit cumbersome, and there's going to be a lot of fallout. I think patients are not going to continue to follow with this. So I'm just wondering if there are any. It doesn't have to be in pancreatic cancer. Is there any thought being given to that?
I mean, you mean patients who haven't developed cancer yet, so screening.
Right. Is there any
So we have that actually for, I'm sure there is for pancreatic cancer. I don't know the details, but for example, for ovarian cancer, where we have a familial component, which is the BRCA1/2 mutant patients, we have a genetic counseling program at Princess Margaret, where patients who have a history or who have a history of either BRCA1/2 mutations or ovarian cancer in relatives, in close relatives, can be screened for ovarian cancer using blood. So we're looking at germline mutations in BRCA1 and BRCA2, and that information is kept because as we know more about BRCA1 and BRCA2, the definitions of mutations that may be of unknown significance now may be known in a few years. So we track that over time so that these patients can be informed whether that changes either how they have to be screened or how they have to be monitored or anything for their family. Yeah.
Hi, Julie. Nice presentation, but that's not surprising. So I do have a question about, in fact, two questions about the liquid biopsy as well, for example, because do you think it's to have a different, in terms of free DNA, in terms of depends on the source of the sample, like say, if you get cell-free DNA from urine, you expect to have, the same type of in the blood as well?
So I'm not sure about urine. I know that serum and plasma have even been compared, and the levels can be actually quite different. You do tend to see the same mutations picked up, but the levels of them can be quite different. And I think in serum you see higher levels of circulating tumor DNA than in plasma, I think, if I'm not mistaken. But in terms of the mutational type, one of the things that we've been studying is whether the same TP53 mutations are found in the blood versus in archival tissue. So we'll compare a patient who's on trial where we have their archival tissue where we've done next generation sequencing for and we've detected a TP53 mutation and check if that same mutation is found in the blood. And in general, you do find the same mutations for TP53.
Yeah, can you tell us how much blood is needed? Is it 30 ml or 50 or is it just 5?
It depends for circulating tumor cells and circulating tumor DNA, and it depends on what technology you're using. So if you're using a PCR-based amplification process, you can actually use less, but you might get less blood, but your coverage is also less in terms of the genome. So your allele frequencies of your mutations, you might need more of it to be able to get allele frequencies as low as 1 or 2%. I think in general we use 10 ml, you can actually already detect ctDNA. The more you have, the better it is in case you can't, but in general we extract the 10 ml tube, and then we extract from the serum.
I want to make a comment. I have no doubts that this is... I don't need one.
Oh, come on, you need one. You deserve one. Come on, come on. You have to be tapered. It has to be tapered.
You know what? And this is Professor Belfort. If you can do that, I can do anything I want. Anyway, thank you, Rubens. We were discussing before Julie presented the fact that there's some people going over a lot of testing of the primary tumor in ocular melanoma, and our laboratory decided to do a lot of CMCs and go over the blood. I think what you called so elegantly liquid biopsy for uveal melanoma is the way to do it, and is the way to go. And I think we should try as much as we can to understand the circulating malignant cells, because if you understand them, doesn't matter if they escape from the eye or don't escape from the eye, if we could train them or we could manipulate them, that the metastasis is not in the liver, that is the way to do it. And in particular in the eye, where it's very hard to do a biopsy. Even fine needle aspiration biopsy, we discussed that today, it's an issue. And Julie said, well, patients sometimes is 20/30, 20/20, and morbidity is a problem. Then liquid biopsy for uveal melanoma, I think is the way to do it. Do you want to use the microphone? Stay here. Are you ready?
Miguel would never forgive me if I had not missed it, so I did it by purpose. Now, Julie, congratulations. I think this is the kind of talk that not only informs, but also kind of wakes up us. And this kind of liquid biopsy is fundamental. I think it's something, as Miguel said, it's going to get more and more important, and is already going on. Any experience on liquid biopsies from the eye, AQs, on these new techniques? We've been doing biomarkers in uveitis, glaucoma, and even cataract with some very interesting results. So I think that in tumors also may be more applicable in many cases.
Well, I mean, I don't know. I know that uveal melanoma liquid biopsies are done currently in the blood, but like I said, for ovarian cancer patients, we also use peritoneal fluid. So I think that would be kind of the similar context, that it's not the blood, but that you have a fluid nearby the tumor.
Yeah, I think there is a kind of prejudice, negative prejudice against going for aqueous humor samples in patients without severe disease, especially in the United States. And we know that it's safe and can help a lot of information for the patient, especially when you use more and more this new technology. So congratulations, very good.
Thank you.
And now the next paper is going to be presented by Dr. Abelardo Rodriguez, an unknown intraocular mass.
Okay, hello everyone. First of all, I would like to thank Dr. Burnier and the biopsy organizers for this kind invitation to participate in this wonderful meeting. And I want to share with all of you the next case. I'm not sure if you agree with my diagnosis. I want to show you. I have no any conflict interest. Well, this is the history of this patient. This patient was a 92-year-old male with no family history. And in his personal health history, he had sequelae of severe childhood trauma to the left eye, systemic arterial hypertension, and transurethral resection of the prostate. He complained of occasional painful left eye, as well as epiphora and itching of both eyes, around 5 months duration. This is the ophthalmic examination when the patient arrived at the hospital, and as you can see, the left eye was very bad. Look, no light perception, and the patient had an epibulbar perilimbal pigmented nodules with corneal glaucoma, and the rest of the exploration was not accessible because it was completely blocked. This is the clinical appearance of the patient as you can see on the left eye. You can see some pigmented nodules in this higher magnification. You can see the epibulbar hyperpigmented nodules surrounded the limbal area. And this is a higher magnification, was a very huge mass of the anterior surface of the eye. And with the B-scan ultrasonography, you can see an heterogeneous intraocular mass. Some of the echoes were hyperintense echoes, another were low reflectivity, you can see with the A-scan ultrasonography the average of the high average of the tumor was around 85% high reflectivity.
Was there any extraocular extension on B-scan?
Excuse me?
Was there any extraocular extension on B-scan?
Well, just the epipulvar nodules.
No, on the B-scan, there seemed to be something growing outside the sclera, there, behind the sclera.
Well,
Where the sclera is.
okay.
Something darker behind it.
Okay.
Maybe, maybe not.
This is the CT scan. If you can see, comparing with the right eye, we can see inside the eye hyperdense mass. This is in a coronal plane, CT, and you can see the same mass, intraocular mass. And at this moment, the clinical diagnoses were malignant melanoma of the choroid with extraocular extension, and the other metastatic carcinoma.
You interpret that, sorry,
Yes.
the extraocular extension would be represented by the epibulbar mass.
Yes.
Nothing behind the sclera, nothing in the orbit.
Not in the
No.
orbit, which is extremely rare. It's a rare event. It's extremely rare event. It is a malignant melanoma. I'm not saying that it's not.
Okay.
It's a very rare event.
Okay.
That without the involvement of the sclera, you would have just the epibulbar mass.
Yes.
What sometimes is not rare is when you believe it is a bulbar conjunctival malignancy, and in fact is an intraocular melanoma involving the conjunctiva. But this is really, unless the tumor has been there for many years, which speaks against metastatic carcinoma, because this would be a much more dramatic case. It's a very rare. Both circumstances, either metastatic or melanoma, is going to be a rare.
Okay.
So the calcification is on the CT scan, you see calcium inside the eye.
Yes.
That's maybe osseous metaplasia of the RPE.
Okay.
Because the eye is completely
Perfect.
eyes is wide or something.
The other thing, which is pigmented, can also be RPE reactive adenomas, and they can become tumors.
Okay.
But it's rare that, again, what impresses me is the epipulvar type of presentation, which makes this case almost unique.
Okay.
As always presented in the case.
Okay. For that reason, the patient underwent to enucleation of the left eye. And this is the gross appearance of the eye. Again, the hyperpigmented nodular mass at the anterior surface. You can see bilobed mass. This is a lateral projection, and you can see the same anterior mass, hyperpigmented in most of the areas. And this is the cut surface of the same. You can see the whole eye is completely full of a mass. And you can see here the epibulbar mass, maybe as a continue to the intraocular mass. Well, let's see the microscopic findings. Here with this power, you can see the sclera, and this is the mass. You can see, as Dr. Singh and Dr. Bernier said, some of these areas were composed of bone, metaplastic bone. But in other areas, you can see solid areas and some structures similar to tubules or maybe glands. But some areas, the cells were completely clear, and in other, with pigmented. Here is another field. You can see some tubular structures, solid areas, and non-pigmented and pigmented areas. Another field, the same, tubular structures, solid area, clear cells. This is a high power. You can see this as a tubule or a gland, and you can see the epithelial cells. Another field, and in some areas, the mass was composed of solid nests. This is a very nice picture because you can see at the top of the picture the cells were composed of melanin, and at the bottom of the picture you can see the solid areas, and most of the cells were composed of clear cytoplasma. We found few mitotic figures in the solid areas, and this the same, the tubules and the solid areas intermingled. Again, the solid areas with the clear and pigmented cells. And with a high power, you can see the sclera, and in this area, the metaplastic bone intermingled with the neoplasm.
Which is responsible for the ultrasound showing high reflectivity. That goes together.
Okay. And the last high power, the same finding, the metaplastic bone, pigmented cells, clear cells. The PAS for us was not positive, maybe a few granules, maybe was glycogen. And this is the immunohistochemistry panel. We performed Bimentin, that was strongly positive, EMA, positive, this cytokeratins cocktail, positive, CK7, positive, neuron-specific enolase, positive, S100 protein, positive, and sanitophysin, positive, but focally, not in the whole tumor. The rest of the immunohistochemical markers, as CK20, GFAP, PSA, and PAP for prostate, were completely negative. Let me show you. This is the Bimentin, positive in most of the cells of the tumor.
This is like a glandular structure.
Yes, look as a glandular structure.
It's coming there.
Okay.
It's getting there.
This is the Biment with higher power. Bimentin again. With the EMA, you can see, for me, you can see the enhancement of the basement membrane of the tubular or glands, the same marker. And this is the curve mix of cytokeratins. You can see many cells strongly positive. The same marker in some other areas, solid areas. And this is the cytokeratin 7, positive in most of the glandular structures.
What you show extremely elegantly is the pattern that's all row of epithelial cells side by side with tumor structures. Sometimes they're more glandular, but if you look, it's really tubular. They go and go and go and then come back. And this is very characteristic.
Okay.
We're not a pathologist, but
There we go. Glad the man speak. You speak.
no, I don't know, but I think how is it like an RPE tumor? Can it be?
Okay.
Close by. It's getting there.
Very-
One more opinion and you may become member.
You can see this. This is other type of cytokeratin. Cytokeratin 20 was completely negative.
Another thing that I'm going to say this because there's a lot of young people here. The fact that he needed Bimentin is important for two reasons. First, because this is Bimentin positive. Second, for all of you that are doing archival review of tumors and lesions, and you have herping blocks that are older than 5 years, please do Bimentin before you start doing your antibodies. If it's Bimentin negative, it's because the immunological qualities of that tissue are no longer good to do immunohistochemistry. Then select your blocks that are Bimentin positive, regardless of the lesion you are studying.
Okay. This is the non-specific, neuron-specific enolase. And you can see not the whole cells, but most of the cells were positive, synaptopsins. And this is the S100 protein positive in many cells. And these markers were to rule out metastatic prostate carcinoma. PSA was negative, and PAP negative too. With all of those findings, our diagnosis was pleomorphic adenocarcinoma of the ciliary epithelium in a T-sick eye.
Dr. Zimmer would say that if you have a bicycle eye, this is the most frequent of all tumors. The same way that the ciliary
Could you please, Dr. Burnier, take the microphone?
the same way that
Thank you.
ciliary epithelium can become metaplastic and produce, on one hand, bone and bone fragments and bone spicula, the same cells can go on the other direction and become malignant. It's not uncommon that you receive a tisical eye, and if you look at the tumor inside, there's only two possibilities usually. Either is an adenocarcinoma of the ciliary epithelium that in children we call meduloepithelioma. That's Dr. Zimmerman's classification. There's meduloepitheliomas, a teratoid, non-teratoid in children, adenocarcinoma of the ciliary epithelium in adults. Or it's a malignant lymphoma, non-Hodgkin. Those are the two possibilities if it's a tisical eye.
Okay.
You agree with me?
Yes, completely. Well, this is a follow-up of the patient a few days after the enucleation. And in a systemic workup, most of the studies were completely negative or within normal range, as you can see on the table. Even the prostate-specific antigen was completely normal, 1.46. Well, talking about this tumor, adenocarcinoma of the ciliary epithelium occurs most of the time in adults with a mean age of 67 years. There was no gender in the largest series I found in the literature by Dr. Lever. They didn't find gender predilection. Mainly tumors are arising from fully differentiated pigmented and non-pigmented ciliary epithelium. And in the past, as Dr. Burnier said, this tumor was called meduloepithelioma, malignant epithelioma, and adenocarcinoma. They vary from well-differentiated malignant neoplasms to poorly differentiated tumors, and for that reason, the term pleomorphic, I think, is very well in play. They can occur in blind eyes as a result of trauma, previous surgery, or other conditions, and commonly are associated with intraocular fibrosis and bone formation, as the case I am showing you. They have a tendency to bleed excessively, intraocularly and extraocularly at the tumor, and the treatment of choice in most of the cases is enucleation, but if they develop recurrence, the exenteration is the best choice. They have a tendency for recurrences, and the neoplasm localized within the eye don't have metastatic disease in the largest series. These tumors with extraocular extensions have metastatic disease, and the poorly differentiated tumors may resemble a melanotic melanoma, squamous cell carcinoma, malignant nerve sheath tumors. Intraocularly, some of the tumors resemble metastatic renal cell carcinoma, as I show you the clear cells, and usually have many mitotic figures, focal areas of necrosis, invasion of other neighboring structures, and the scleral invasion is the most important feature of a fatal outcome. This table for me is very, very useful because you can see the main differential diagnosis histopathologically from pleomorphic adenocarcinoma of the ciliary epithelium with metastatic adenocarcinoma. The first one is localized and most of the time unilateral, and the other is multicentric and bilateral. The origin is ciliary body most of the times, and they can develop glaucoma. And the metastatic adenocarcinomas can develop in many areas: choroid, ciliary body, iris. The architectural patterns of this primary tumor most of the time is solid, tubular, pleomorphic, or all of them. And in the metastatic adenocarcinoma are similar, but you can see sometimes papillary and glandular pattern. This is a very useful morphological marker, the thickness of the basement membrane. Most of the time in the primary tumors, the basement membrane is thick, and in the metastatic adenocarcinomas, they are thin. And finally, the markers, as I show you, most of these combination are positive in neuroepithelial markers, and in metastatic adenocarcinoma depends the primary tumor, such as lung, prostate, or other areas. Well, in conclusion, malignant tumors of ciliary epithelium in adults are rare. Clinical diagnosis, you need to think about it when you find an epubulbar mass and or proptotic eye of recent duration in a long-standing blind eye. Main differential clinical diagnosis is uveal melanoma if the tumor is pigmented. The histopathological patterns, solid tubular pleomorphic. The origin, ciliary epithelium. The main histopathological differential diagnosis is metastatic adenocarcinoma, and finally the extraocular extension have bad prognosis. Thank you for my collaborators, and these are a few pictures some years ago with the Burnier family, and thank you for your attention.
So, any additional comment or questions? Okay.
Thank you, Dr. Abelardo. I'd like to invite Professor Rui Proença, who's going to speak to us about a black and white melanoma.
I want to thank you, Dr. Miguel Burnier, for many things. One is friendship since '89. The other, to present me, to have introduced me to Tony O'Neill in that year. And for the meeting, for everything, for teaching. So, I'm running some units, uveitis, oncology, and ophthalmic pathology in the University of Coimbra Hospital. And now we are the National Reference Center for Ocular Oncology. And I want to present a simple case. And Miguel has talked about this case today. A rare one, because there are in the same eye 2 different tumors with different expressions, non-pigmented and pigmented one, and both with different cytogenetics. In this case, it was curious because I look at this slide and see what is happening in this eye. 2 months ago, we received a case referred from the Lisbon Portuguese Institute of Oncology with a suspected melanoma, 47 years old woman with blurred vision in the left eye for 1 month, and past systemic history of a colorectal cancer, underwent surgery and chemotherapy, the gastric bypass surgery. The vision was low. Otherwise, the eye was a remarkable anterior segment. We performed a systemic workup. Everything was normal, including a PET scan. These are the image, a black mass and a white mass in the same eye. Here you can see it's a huge tumor because it reaches almost the ciliary body, and the white portion was near the optic disc. Here we can see black one and white one. The ultrasound undoubtedly is a melanoma, uveal melanoma. The white portion, mushroom-shaped, here about 7.4 millimeters. And the other portion, black one, it's huge and reaches almost the ciliary body. This is the OCT. Drop-in vision was of a neurosensory retinal detachment. And the mass, black and white, underwent brachytherapy with iodine, 20 millimeters comes plaque. Here we have to take off the medial rectus, and it was the last, performed last month. And here we can see the plaque, the ultrasonography of control of the plaque. All the tumor was enclosed in radiation field. And this case is very similar to that presented by Dr. Bournier in this team. And different tumors with probably two populations. I haven't done biopsy, but I think different cytogenetics in the same tumor is something special, and the value of these cytogenetics is doubtful, I think. But normal chromosome 3, monosomy 3, what is the meaning of this gene expression? It was discussed. We don't know the value, but two phenotypes in melanoma cells can occur, a low grade and a high grade, and probably they can coexist in the same eye. But what is the behavior after brachytherapy? In Miguel's case, I think the worst tumor was the pigmented one. That's right, Miguel?
The pigmented one was monosomic 3.
Monosomic.
This is one tumor. The difference is the non-pigmented one was there for 13 months.
Mm-hmm.
We know. The pigmented one, double the size of the tumor, the pigmental area, was not there before, and in 13 months, double the size of the tumor. What we did was we faked that this was two different tumors and classified non-pigmented A on your left-hand side, pigmented B on your right-hand side, and pigmented areas, monosomic 3, non-pigmented, pigmented, non-monosomic 3. Also, all the other prognostic factors, cell type, vessels, chromosomal
Were
type,
equal.
they were non-existent in A and existent in B. Meaning, this is a clear transformation. And this patient never had treatment.
Never.
Never.
Mm-hmm. And what is the behavior of these two types after brachytherapy? What is going to happen? What non-pigmented mass is going to respond?
Doesn't matter. There are 5 or 6 studies correlating monosomy, gene expression, with regression rate. There is no difference.
No difference.
What I think we're learning more and more is that to predict that's a high-class tumor, that's absolutely certain.
Mm-hmm.
You just have to be careful when we say low-class or low aggressive class tumor. We have to say to the patient that we cannot guarantee that it will stay low for the right aggressive patient life. That's all.
But it is curious because 1 month after brachytherapy, this white tumor start to respond and to have exudation around. We can see here. And the other mass is just in the same or probably increased a little bit in dimensions, the pigmented one. So there are these kind of tumors. I find one, and I think it's a funny case, and I don't know the response will be after brachytherapy. It's just 1 month of brachytherapy. And that's the case I want to show you. It's a simple case, but we have talked about this today, and we don't perform biopsies, and probably they are not important in clinical decisions, and I prefer blood biopsies. Thank you.
Any comment or question to the case?
They're beautiful quality ultrasounds.
Yeah.
Yeah, they're very good quality. They're hard to get. Intraoperative, such high quality. We try all the time.
Yeah.
Very good quality. Very good.
Thank you.
Did you notice any extrascleral extension in the ultrasound?
No.
One that you noticed down the right-hand corner. You can put it all back again. It looked like it.
No, no. There wasn't.
Go ahead.
You guys continue there.
Thank you very much.
Thank
No, we're just admiring our competence because we forget to give you the certificate. So by the end, we will approach you individually and yeah, handle the certificate.
Two things you can do. Either approach them individually or you call the magic name.
Tiffany, yeah. But Tiffany's been overwhelmed, so me and Professor Sarnier are going to take care of that. No worries, Tiffany. Would you like to invite
Yeah.
Dr.
Then we are moving to other part and starting our three lectures by guest speakers. And the first one is going to be done by Dr. Peter Metrakos about the Cancer Research Program on the McGill University Center Research Institute.
Well, good afternoon, everybody. Thank you for giving me the opportunity to discuss a little bit what we've been doing at the MUHC or McGill with a redevelopment project that's been ongoing. We're very excited. It's a $1.6 billion redevelopment project, and it includes the refurbishing and reorganizing of the Research Institute. My disclosures are that I can never be an ophthalmologist. I just saw the pictures over here. I'm a liver surgeon by training, and I was always squeamish when I was a surgical resident whenever there was trauma involving the eye. So my hat's off to you, to the whole audience here. And secondly, Tiffany never gets overwhelmed, despite Miguel's efforts. Let me see, do we have? So obviously there's been cancer research going on at McGill for a long time, but it was fragmented and it was across multiple hospitals. In fact, when we were putting the program together to single-site it, as we have now, I realized that I didn't know everybody, which is rather surprising, you know. But nonetheless, that was the truth. But in order to talk about the cancer research program and how we've put it together, we do have to talk about the redevelopment project a little bit. And so this is the McGill University Hospital Center. It was composed of the Montreal General Hospital. Here we call it the mountain site. Actually, we can actually just put the, let's see if it'll work, yes. Then we had the Royal Victoria Hospital, which was my home. Next to it is the Montreal Neurological Hospital and Institute. And of course, part of the Research Institute was at the Montreal General, at the Royal Vic, at the Montreal Neurological. So every hospital has had its own component of a research institute, including the Montreal Children's, and including the Montreal Chest Hospital, a specialized hospital for respiratory issues. And then more recently, we co-opted the Lachine General, which is a community hospital. So the plan was, I mean, it's changed many times over the years, but the final plan was that the Montreal General Hospital would be the mountain site, and then we had what we call the Glen Yard site, which included the Royal Victoria Hospital, the Montreal Children's, the Montreal Chest, and we anticipate the Montreal Neurological to come to the Glen site in the next 4 to 5 years. So this is what it looks like at present. So you have the Children's, the Royal Victoria Hospital, the Montreal Chest. We've added a cancer center, which we did not have before this site was built, and also a Shriners Hospital that specializes in pediatric bone deformities. In the back here is the Center for Translational Biology, which I obviously will be talking about. That's our basic science cancer research home. And there is also a clinical trials unit, or what we call a SIM center, built into the hospital, but I'll detail that in a minute. This is what it looks like 2 o'clock after a liver transplant at night, and it's all lit up. I was able to take a photograph going home. So the vision for, as this hospital and research institute was being developed and the plans were being put together, the vision was to bridge the gap between biomedical research and clinical medicine, speed innovation and accelerate translation from basic discoveries to introduction into the public arena, bring together pediatric and adult research programs, focus on improving the health of individual patients throughout their life cycle, so from birth to death in one institution, and set the stage for transition to patient-centric care, personalized care or precision care, whatever the term that you prefer, currently where most of us are using precision care. The MUHC RI, Research Institute today, is ranked the second research hospital in Canada. It's first in Quebec, has a $175 million annual budget, 550 researchers, 220 labs, 1,100 students, 1,700 peer-reviewed publications per year, and has 1,500 ongoing clinical trials. It's not just cancer. I'm talking about the whole research institute. The patient population we serve is that we see about 15,000 ambulatory visits per year. We receive almost 40,000 inpatients yearly, 35,000 surgeries per year. The 470,000 square feet of the Glen campus is dedicated to research, and 150,000 square feet at the mountain site, or the Montreal General Hospital, is dedicated to research. So it's a reasonable sized operation. If you take an aerial view of the Glen site, this is the new digs, the new hospital, the new research institute. The E-Pavilion right here in blue is the Center for Translational Biology, which is basically basic science unit. It has 120 principal investigators under one roof. The red component here, which is within the hospital on the 4th floor, as I mentioned before, is the Center for Innovative Medicine. And you'll see that it's basically a hospital within a hospital. So it's a totally self-contained clinical trials unit with everything that you would anticipate in a hospital, except that it's not for typical clinical use, it's for clinical research only. Across the street, because all we need is to access this group is a bunch of computers, is what we call the core. And the core is basically 80 outcomes researchers, so epidemiologists, statisticians, health economists, and so on. So the CTB now has sort of state-of-the-art laboratory set up, so that it's built to be research neighborhoods, so that you have people that are interested in the same sort of work grouped together on each floor with open concepts so that you can expand and contract depending on how big your lab is going to be. We have multiple platforms with sophisticated equipment. We were able to purchase $150 million worth of new equipment to put into this unit. And we have a state-of-the-art vivarium with imaging facilities. I'll talk a little bit about that in a minute. We are able to accommodate 15,000 cages for small animal work. So the platforms include immunophenotyping, molecular imaging, proteomics, drug discovery, histopathology core, and a biobanking core, which is not completely up and running. We're just installing a state-of-the-art Lyconics storage system for this. The vivarium also contains a containment level 3A facility to study tuberculosis, influenza, and HIV. And we have an imaging platform for small animals, which includes a 7 TELSA MRI and a CT SPEC. This is just another schematic of the Glen site. The Center for Innovative Medicine is the hospital within a hospital that I was talking about, which is on the 4th floor, embedded in the hospital. Has a project management office, clinical trials management unit, quality control, data management, and statistics for the trials. And it has its own, sorry, this kind of hides it, but it has its own imaging platform. So CT scan, ultrasound, and so on are dedicated totally for research. You don't have to compete with the clinical side at all for these trials. We also have cardiopulmonary suites, echocardiograms, non-invasive vascular studies, locomotive tests. We have a 12-bed phase 1 unit. We also have an experimental OR to develop new equipment and a simulation suite, 3D printers, experimental procedure rooms, GI endoscopy and bronchoscopy. Again, totally dedicated to performing clinical trials. No competition with the clinical side. The core, as I described before, is a outcomes group. They don't need lab space. They do dry lab work. So they basically need desk space, computers, and servers, and sort of data management themes. So, so we have these 3 sort of large platforms, and they have miniature platforms within each of those platforms. And we have generated 8 research programs out of that. 5 of them are located at the Glen site, the new place, and the other 3 are located at the Montreal General site, the Mountain site. And the way you generate a research program, for example, the cancer research program goes to the Center for Translational Biology and co-ops all the basic scientists that are doing cancer work. Then we go to the Sim Center, get all the clinical researchers that are doing clinical cancer trials and research work. And then we go to the core and get our outcomes people that are doing cancer work. You put all that together and you have a program. And the cancer research program between students, PIs, and postdocs, and everybody together, we're roughly around 300 strong. So all of a sudden we realized that we actually had a program which was just dispersed everywhere. So the opportunities are, we haven't even begun to sort of take advantage of the opportunities. We see that the collaborative efforts are quite easy now. You bump into people in the hallway and so on. But we have developed themes within the cancer research program. There are actually 5 themes. The last one is, I've put it separately because they're people from the core, but they in fact integrate into the other 5 themes. So the first theme here is urological oncology, and they're very, very strong in prostate and bladder cancer. This group actually was well developed before they joined us. They were all unified more or less at the Montreal General site before they moved here. Molecular translational oncology, this group was all over the place, and some of them were recruited from outside the MUHC, in fact. And they basically work, signaling and pathways and that sort of thing. We have a genetics core group. Primarily, they're very, very strong on ovarian and pancreatic cancer. And the theme that goes across all the cancer genetics group is the BRCA mutants. McGill was part of the group that initially reported BRCA mutation 20 years ago, was it, Miguel? And then we have the cancer metastasis group where Miguel and I are both part of. In fact, most of the group works on, in particular, liver metastasis. So we're quite a strong group in that area. And then this group here is basically a group of radiation oncologists and medical physicists, and they work on making radiation an effective therapy for patients and do between molecular biology and then studying the actual physics of radiation and combining the two. And then this is the group that I was talking about that are actually outcome researchers, but they belong to one of the other 5 groups. You know, for example, Alice here belongs to the urological group, and Miata belongs to the liver metastasis group, and so on. So what can you do now when this? What this facilitates is precision care. And the vision for the Cancer Research Program is to establish, among other things, is to establish translational clinics where patients are not only patients that are in particular trials that are either funded by pharma or investigator-initiated trials, but to develop translational clinics where every patient is treated in a very unique fashion. So you get either surgical specimens or biopsies from patients that are followed at the SIM center, and they're banked and they're also analyzed genomically and proteonomically, whatever you're going to apply to this, whether it be liquid biopsies like Julia was talking about. You have some sort of high throughput system of screening for drugs that are effective. Here I've put down tissue slicers, but it could be organoids, it could be other ways of doing high throughput screening. And that goes back to the patient. At the same time, using the facility, the Vivarium facility, and we've already established patient-derived xenografts now in nude mice for a number of tumor groups. Then you can actually do preclinical trials that can then again feed into treating that patient. I put this example up. It's because it's what I do. So, but it could be related to any kind of tumor. So, I'm talking about here of colon cancer liver metastasis, where the patient would be seen, thoroughly biopsied, and if necessary, perform laparoscopy to get enough tissue. And there are 2 things that will go on in parallel. Components of this are already happening at our institution. The patient will be, as per our tumor board, will receive the current standard of care as things start up. But as things develop on this side, meaning the genomics part, or if we have xenografts that we've tested certain drugs, meetings between physicians and scientists will occur regularly, and as this information trickles in, you can actually alter the therapy that you're giving these patients. Some will go to surgery, others will not and will progress. When they progress, they actually can be refunneled back into this loop and reinvestigated. So actually, I'm very happy with our new facility. The only thing that I'm going to miss about the Royal Victoria Hospital is the view that I had from my office, which is here. Thank you very much.
Thank you very much for your wonderful lecture.
I have just a quick question. What is robotic biobank?
That's the electronics that I was saying that we're going to get. So basically, you have a robotic arm in an encased. People can hear me, I think, but so basically, a laconic system is it's a storage system, -80, and you have a robotic arm that will get your specimen so that you don't have a freeze-thaw issue. So if you have to take your specimen out and kind of you manipulate it, then the specimens that are in that box also get sort of mildly thawed, and that degrades the tissue. Whereas in the robotic arm, it stays within the -80 and just gives you the particular specimen that you want to take out without freeze-thawing the rest of the specimens.
Okay. Can I ask permission to introduce the next speaker instead of you guys? Beatriz Wong is one of the best dermatologists in the country. Beatriz Wong certainly is one of the persons that have more experience with the skin melanoma in the country. She's a professor of dermatology and oncology. She's a very dear friend of mine. She's a wonderful person, and she and I have a dream to have one day a clinic where the skin melanomas and melanomas everywhere, including the eye, would be seen together. I cannot tell you, Beatriz, how proud and happy and privileged that I feel that you are here today.
Oh my gosh. I don't think my talk is going to live up to the introduction. Thank you very much. As you well know, Dr. Bernier has a world-renowned laboratory. What you may not know is that for as long as I've known him, maybe not in the beginning, he's always had dermatologists in his laboratory. Coincidence? I don't know. So this is going to be a very jam-packed talk. What I wanted to do is bring you up to speed on the new therapies in cutaneous melanoma. It's been incredible, the changes that had happened not only in the past 10 years, but even in the past 5 years. It's been very exciting and very rewarding for us. As Dr. Bernier alluded to, we do have a lot of cases in cutaneous melanoma. He has one of the largest cases or caseloads of ocular melanoma. And that gives us a chance to be part of many clinical trials, and that's also what makes it very exciting for me. So what I'm going to do is very quickly go over some statistics for you in Canada, show you some of the clinical subtypes of cutaneous melanoma, and then go straight into therapies. So in Canada, it's estimated that over 6,500 Canadians will be diagnosed with melanoma, and close to 1,000 of them will die of their disease. As usual, more men than women will be affected and also will be killed by melanoma. Lifetime risk currently is 1 in 74 for women, 1 in 57 for men, and this risk, lifetime risk, is increasing exponentially. What I want to show you in particular here, this is from the Canadian Cancer Society. I'm sorry it's very small, but melanoma is this tan one. And this is stratified as to age. So in the young age group, 15 to 29, melanoma is the 4th most common cancer in young adults. Same here, still young adults, 30 to 49. We're sort of here below prostate, breast, and lung, but it's an important disease. And again, the numbers are increasing exponentially. Incidence rate is increasing by almost 3% per year. And Canada is always in the middle of the road. So here we are in terms of global incidence rates. The highest incidence, and these are too small for you to read, are in Australia and Israel, have the highest rates of melanoma in the world. So this again is a quote from the Canadian Cancer Society, all to let you know that they're probably underestimated because we don't have a tumor registry per se for melanoma in Quebec, so the numbers are not really well defined. But they expect a 72% increase in the number of cases over the next 30 years. So what are we looking at? They're obvious sometimes. This is a lentigo maligna. But sometimes it's not that obvious. This is again a lentigo maligna, but I know he's an old redhead. I know he has a history of psoriasis, had a lot of UV treatment, so I'm looking for skin cancers. This is a little bit more obvious. This is a superficial spreading melanoma, and you can see that his nevus is changing, and that's what I ask my patients to look out for. This is very obvious, and the patient obviously should have presented earlier, but again, this is a male, so that he doesn't look at the back of his legs too often. You can tell this is a calf, this is a sock line. And this is a nodular melanoma. And if it weren't for the fact that it has already started to have a satellite metastasis, which is pigmented, you might not have melanoma as your first diagnosis, and sometimes you miss it and they present late. This is the sole of the foot. This is a little bit of a bizarre case because this person is white. Most of the acrolitigious melanomas that we see are in pigmented people, Hispanics, blacks. Even though melanoma is not common in this population, this is the most common type of melanoma that they'll see. And this is the acrolitiginous is most commonly seen in this population group. Not a melanoma, but I'm often presented with these cases. And the reason why I know is because you can see from here the nail fold is not involved. And this is a true, again, acrolitiginous melanoma involving the nail plate. This is, again, a melanoma. Unfortunately, much more advanced, so it's lost all its pigment. And this is metastatic melanoma. Again, you may not be able to know if you just saw this patient. Obviously, it's a biopsy diagnosis, but if you have the history of melanoma, this is obvious. Again, these are metastatic melanoma. These are actually seborrheic keratosis. We all get them, so don't all come rushing to show me these. And again, metastatic melanoma. So you can see why melanoma is not a surgical disease. It's a systemic disease. UV is one of the main causes for us, and we're talking in particular for UVA and UVB. We know that it can transform moles, and we know that it can induce new moles to come up. And we know that tanning beds are a huge source of provocation of skin cancers in our population. And even having just 10 sessions, you can see a strong association with melanoma. But obviously, there are melanomas that are not caused by UV irradiation, including ocular melanoma, so there are other factors involved. And we know that melanoma is an immunogenic tumor. We know that you can see regression of your melanomas. We know that you can see even vitiligo in patients who develop melanoma. And we see higher rates of melanoma in immunosuppressed people. And this is a clinical presentation. You can see that you're starting to get a vitiligo-like response around this congenital nevus because you're trying to fight off or destroy this nevus. And this is a lentigo malignant melanoma, but you can see here you're beginning to lose the pigment in your melanoma. And again, that's an immune response. Survival rates of melanoma are directly related in cutaneous melanoma to the depth of the melanoma when you find it, and that's called the Breslow depth. We don't normally use Clark levels anymore, which is the way that we used to describe melanomas, except for melanomas on the face, because the skin is so thin, so that the actual millimeter measurement is not as valid. So this is an old slide, but just to show you, for us the most important number is 1 millimeter. When we get to 1 millimeter, that's when we offer our patients sentinel lymph node biopsy, because that's the number where we think that systemic involvement is more likely. So AJCC staged melanoma in this way. Stage 1, less than 1 millimeter in depth, and that's not very deep. Stage 2, greater than 1 millimeter in depth, but no nodes involved. Stage 3, any nodes involved, and stage 4 is distant metastases. And why is this so important? This is a more detailed map, all to show you that two things that you see on histological slide: ulceration, histological ulceration of the tumor, or the presence of any mitosis will shift your lifespan curve down. Just something as simple as that. Why? Because it's so drastic. All right, so as we said, stage 1, your melanoma is less than 1 millimeter. If we take a 5-year survival curve, you're in the 90s. But if your melanoma is greater than 1 millimeter and you don't have nodes involved, nothing, no nodes involved, your 5-year lifespan risk drops down to 70%. It's huge. It makes a huge difference. Stage 4, distant metastases, survival rate extremely poor, but this has changed so radically in the last 5 years. This curve is from 2001. When the next AJCC guidelines come out, there will be new survival curves, and they'll be much more optimistic. So let's get to therapy. So if we're talking about a primary melanoma, it's still a surgical disease. Wide excisions, clear margins, lateral and deep. And we only go up to 2 centimeters when we're talking about wide margins. Why? Because after that, we're talking about systemic metastases, and it's not a surgical disease anymore. How about adjuvant therapy, where you offer to patients when they have lymph node involvement? The only thing that has been approved by the FDA in Health Canada is interferon, okay? And we usually will give it for a high dose for 1 month, 5 times a week IV, and then maintenance phase, 3 times a week subcutaneously for a year. Has modest effects at best. We hardly use it anymore. We haven't given interferon to a patient in the past 5 years because the effects were modest and it's a difficult disease, a difficult treatment to go through. What we have done, we've just finished a clinical trial using BRAF inhibitors as adjuvant therapy. We've given it to them daily for a year. The trial just closed, so it will be a couple of years before I can give you any results from that. But that's very exciting for us to find out if there's been any benefits at all. The other thing that we are starting right now is actually a vaccine adjuvant therapy trial, and that also should be very interesting. We're enrolling patients right now. How about therapy for metastatic melanoma? And this is where all the fun is. So interleukin-2, we don't use anymore. We used to give it systemically. It was very difficult. Patients were in the ICU with capillary leak syndrome. Right now, we're using it off-label, injecting it into satellite metastases. It does work the same way that we used to inject BCG or even levamisole into satellite metastases. It's for disease control only. Melanoma vaccines, as I just alluded to, using it in stage 4 didn't do anything, but as an adjuvant, it might be of great benefit. Radiotherapy, we still need a lot of studies on this, but basically we're using it for palliative purposes. We will irradiate lymph nodes that have recurred. We use it for bony mets and brain mets, but as a standalone therapy, we don't. We do offer it in head and neck, and vulvar, and vaginal melanoma. Chemotherapy, again, response rate very poor, only about 5%. DTIC is the only one that's been approved by FDA and Health Canada. The oral form is temozolomide, and we use that because it crosses the blood-brain barrier. Carbotaxol can work as well. And one of our surgical oncologists does ILI, or isolated limb infusion, using melphalan for metastases located to just one limb. So there were 2 branches of systemic therapy that have been really exciting. One is targeted therapies, and you all are aware of the MAP kinase pathway, where the bulk of the research and the bulk of the medications have come out. We know that 50% of melanomas have BRAF mutations, mostly in younger patients. And in this slide, you can see that in younger patients who have non-chronic sun damage, they're mostly BRAF mutated. Other types of melanoma, such as chronic sun damage, acral, or mucosal, are BRAF wild type and tend to have KIT mutations in them. You all know this pathway, so I'll just skip through that. We're hoping right now for the to do screening for the BRAF mutations, we have to send everything to the Jewish General Hospital, a different hospital in the McGill system, but not part of the MUHC. With the load of cases that we have, we'd like to bring it to the MUHC, so I do have to talk to Dr. Bernier about that. So very quickly, all of this dates from just 2010, okay? So really in the past 5-6 years. This is a fabulous picture. This is after 2 weeks of using a BRAF blocker. This is patient number 1, and this is a PET scan. Disregard the brain and the bladder, but all of these mets, within 2 weeks of taking an oral medication twice a day, had 70% of his metastases disappear. It was amazing. We had the largest cohort of patients in this clinical trial in Canada. And they were just melting in front of your eyes, their metastases. It was the most exciting thing I've ever seen. Same thing, this is his liver, and this is his liver after 2 weeks. Duration of response, however, was short, roughly about, the longest about 9 to 12 months, average was about 8 months. Overall survival, we gave them a year. But a 63% reduction in dying of melanoma, at least for a short period of time, is amazing. Everything is compared when you do the clinical trials to DTIC because that's the gold standard. This was the overall survival curve. This is the progression-free survival curve. The side effects, mild most of the time, but paradoxically, the most important one for my patients was photosensitivity, and this is a second-degree burn that my patient got just after being out in the sun for an hour. She just forgot to cover up the V-neck of her chest. One of the molecules, which was vemurafenib, there was a higher incidence of keratoacanthomas, or early, if you like, stage squamous cell carcinomas. The other molecule, which is dabrafenib by GSK, we saw less of these cutaneous side effects. But the problem was that everybody relapsed. Response rate, if it happened, which was in 50% of the cases, was extremely fast, within a couple of weeks. But they all relapsed, and once they started to relapse, it was fast. It was like an explosion. It's almost like you had a dam that had a crack, and all of a sudden the water went through and the water just spewed out. And it was due to reactivation or bypassing the MAP kinase pathway. So we thought, why don't we go a little bit lower on the pathway? Let's block MEK instead of BRAF. This is in 2012. And again, this is an oral medication given once a day. Again, the trial was comparing results with dacarbazine. Progression-free survival was actually shorter with the MEK inhibitor than with the BRAF inhibitor, even though that the side effects were less. This is the progression-free survival curve. If you compare the BRAF to the MEK inhibitor better well tolerated, but not as effective. So we combined the two, right, BRAF and MEK inhibitors. This is November 2012. So you're blocking the same pathway, open label study, both given orally. The green is curve is the combination of the two. The green is with the higher dose of the MEK inhibitor. The yellow is with the lower dose MEK inhibitor, and this is just with the BRAF inhibitor itself. So you can see that it was more advantageous. Actually, the combination of the two medications had less side effects, and the progression-free survival rate was 9 months instead of 6 months. So this was fantastic, double the price, but much more tolerable for the patients. And in fact, now it's first-line treatment for BRAF mutated stage 4 melanoma, and this is what we do routinely now. There are two companies. GSK was bought out by Novartis, so it's either the Novartis or the Roche molecules that we're using. Other targets have been disappointing so far, at least for cutaneous melanoma. So at the same time that the targeted therapy branch was being developed, immune therapy was being developed. And what we're doing is what they like to say is releasing the brake on T cell activation. So as you see, when the T cell binds to the antigen presenting cell, you need, when you bind the CTLA-4, when it binds on, you actually slow down T cell inhibition. So when you use a CTLA-4 inhibitor, like ipilimumab, the T cell stays on, and you continue the immune response. So again, 2011, ipilimumab plus dacarbazine versus dacarbazine alone. It's given IV. Here in the trials, it's given at 10 milligrams per kilogram every 3 weeks. That's not what we got approval for. You can see the effects are modest. 11 months versus 9 months survival rate, but the median duration of response was much longer. So if you did respond, you responded very well, and about 20% of people did. We got approval at much lower doses, at 3 milligram per kilogram, and that was because of the side effects. The other issue with ipilimumab is that response is delayed. It takes 3 months for the immune system to start to get kicked in. So if you have a rapidly progressing melanoma, we just don't have time to give you ipi. Side effects were immunologic, as you can imagine. And so a lot of people don't have any issues with that, but unfortunately we did have one patient die on us on the trial from a colitis, and some people do actually develop permanent hypothyroidism. The other molecule, which is very interesting, is PD-1. And again, it's an immune checkpoint. It has 2 ligands. The important one seems to be the PD-1L1. So when PD-1 is bound on the lymphocyte surface of the melanoma cells, it downregulates T cell function. So you want to block that receptor. And let me just show you this cartoon. So you can see right here, we want to block this binding so that we don't turn off the T cell activation. 2012, we looked at the PD-1L1 antibody. Also give an IV, give it every 2 weeks or 3 weeks, depending on the molecule. Much better tolerated than IPI. The immune-related side effects are the same, but much less, and toxicity, which much less. Importantly, Keytruda, which is the Merck molecule that got approval by the FDA and in Canada, it received approval as first-line treatment. So anybody that has metastatic melanoma that is unresectable, they get offered PD-1. In Canada, we have to wait. You have to fail other treatments. So if you're BRAF wild type, you have to fail IPI. If you're BRAF mutated, you have to fail the BRAF blockers before you're allowed to get Pembro. But look at these survival rates, 61% at 1 year and 44% at 2 years. This is incredible, incredible. I mean, with DTIC, we're talking about 5% survival rate. And it works so much more quickly. Within a month or 2, you're going to see shrinkage of the tumors. Nivo is the other PD-1 inhibitor. It's called Opdivo by Bristol Myers Squibb. Same thing, it works better if your tumor cell expresses PD-L1. And actually, we need to be able to do the tests on our tissues to see that our tumor has this so that it's more targeted, our treatments. Again, given IV, but every 3 weeks. The latest combination is Nivo and IPI. And this is being offered in trial for us, but it's been accepted by the FDA in the United States. The combination, overall response rate 60%, 85% survival rate in 1 year. This is incredible. So I like this chart because you can see how melanoma treatments have developed so quickly. This is 1960s, in 1970s with DTIC. All of a sudden, you get to interferon, which we don't use anymore, IL-2, which we don't use anymore, really, ipilimumab, pegylated interferon, which we don't use, the BRAF inhibitor, the combination BRAF inhibitors, then the Opdivo, which is Nivo, then the Pembro, and then the combination, which didn't even make it onto the screen. Oh, there we go. Okay, so it's a revolution for us. It has changed our lives. Melanoma is no longer a surgical disease in our hands. Now at Tumor Board, we talk about, do we need to offer this patient surgery? Are we giving our patients benefit by offering surgery? We have a lot of new trials in the pipeline, and that's based on the fact that we have a multidisciplinary group that meets and treats our melanoma. We're a huge group, including Dr. Bernier's group. And as another cancers, the only issue is, like, thank goodness for the trials, because these medications are expensive. We're talking about over $100,000 a year for the course, and these are given until either the cancer recurs or they run out of money, essentially. So this is an issue for us to deal with here in Canada and everywhere else in the world. But it's an exciting time for us. Thank you so much.
Dr. Wright, thank you for this wonderful overview, because we touched on some of this in uveal melanoma as well. But somewhere along the line, I just want to hear your views. As the drugs change from treatment for metastatic melanoma, same drugs then start being considered in adjuvant setting. Just your thought on that process, how you move drugs from effective or even sometimes not very effective drugs for systemic therapy, systemic disease, to adjuvant setting.
As I did allude to, we were part of the VIMU trial for using as adjuvant, so we offered it to our stage 3 patients. We have a vaccine trial that's for, again, stage 2C and 3 patients. But these are pretty much industry based because of the cost of the drugs. Our government can't afford for us to do self-sponsored studies. But it does take a lot of patients in adjuvant trials to be able to see a benefit. So it's going to be a world cohort. It's not going to come out of one institution, that's for sure. But I think there is a role, especially I think in the immune modulating more so than the targeted molecules that will be a benefit. And whether the targeted molecules are going to be a mainstay, I don't know, because they are short-lived, the responses. So if you like, we're almost using them now as a stopgap measure, especially for rapidly progressing disease, to give us the time to offer the immune-mediated medications. I think the problem is that we are sedentary, except for the 2 weeks of the year where you have to go to Mexico because you're so bored of the snow in Canada. And we think, and it's been this way for a long time, we feel that this acute exposure to UV may be more carcinogenic. And, where we used to be outside all the time, people sort of may have self-selected, like people who didn't tolerate sun just stayed out of the sun. But now if you're spending a couple of $1,000s to go south, you want to show everybody that you went south. Yeah.
If I were a past president of the United States, what would I receive?
I beg your pardon?
If I were a past president of the United States,
Yes.
what would I
receive? What did the past president of the United States, Jimmy Carter?
If he was, yeah.
No, I did not. I do not. But there have been, yes, and it was diagnosed, 2 years ago, so he would have been offered. And of his age, I would assume he was offered IPI, would be my best guess. But we had a premier of Quebec, Robert Bourassa, also died of melanoma. He went down to the NIH and received TILS therapy. With Rosenberg, which unfortunately did not work for him.
Thank you very much. Thank you.
Oh, sorry, there's one.
I'm sorry.
Right now, what we do is anybody that is a candidate for adjuvant or systemic therapies, i.e. stage 3, stage 4, we routinely send them for the BRAF, NRAS KIT mutations, even though we don't have anything to offer for KIT or NRAS, but we suspect something may be coming soon. So that's all we have right now. As I said, we want to be able to test for the PD-L1 because then we can, better self-select to offer Pembro or Nivo. Great. Thank you so much.
And our last speaker is Dr. Ran Simpson, and he's going to talk about uveal melanoma in 3D.
The great thing about Dr. Simpson, we don't have to introduce him. No. Everyone knows him. He was the first president of the WC that was in Canada in 1995, right?
94.
94. he's certainly the man who does ocular melanoma in Canada, that better known internationally and has more experience than anybody else. Honor and a privilege to have him. I promised him that I would say some words in his behalf in public, because the election is happening in about an hour, and he wants badly to get into this society.
I'm wondering how much it costs for registration.
$57,000. Payable to TPMB Swiss bank account.
I see. Well, it's a thrill to be coming back to Montreal for me, because this is like a second home. A few years ago, and of course, in fact, I saw my first UV melanoma just up the street at the Montreal General Hospital many years ago. And Miguel and I have traded certainly individuals back and forth from Toronto to Montreal, and we've been delighted in almost everybody he sends us, and I hope vice versa. But we've had a long experience together in the same business of UV melanoma, and so it's really a treat to come back to this wonderful city. I almost came here and stayed here, but other things took me away, but it was close. This has to, I just show this slide because there is an ongoing basketball situation in North America that has two teams. And one of them comes from this city, which is the Toronto Raptors, and the other one comes from another city, and I think it's Cleveland. I'm not sure. Is that right, Arun? Is it Cleveland? Cleveland Cavaliers? Anyway, we're kind of neck and neck. It's a desperate situation. We've heard some wonderful rare diseases this morning. And so I thought we'd step back and show a really common one. That's uveal melanoma. It really isn't, but it has all of these features that I think that are important to at least keep in mind. And we have different ways of managing the disease. Certainly in North America, in our region, it sort of depends on the institution, it depends on the resources, depends on tradition, depends on who's looking at novel therapies, etc. But it has a pattern, and I thought I'd just review this pattern of how we might manage uveal melanoma. Just to answer in part Ruben's question this morning, in Finland, approximately 12 cases out of 1 million are recorded each year for this disease. 12, whereas we might have 6 to 8, and in some areas like Buenos Aires and Argentina, it might be as low as 2. So there is some regional variation. For some reason, it occurs more commonly in the Nordic areas. So I've said 3D. You don't need special glasses for this, by the way. But in 3D, we look at how we can diagnose this disease. We look at how we can describe the disease in terms of classification and staging, which is a relatively new approach. And we also look at, once we've described it, how we can perhaps differentiate the disease, and because it impacts treatment, it impacts survival in many ways. In this instance, it's pretty easy to diagnose this disease. This is a nevus, isn't it? And so that we don't really want to worry too much about this. And in fact, 15 years later, this picture was taken, and that nevus hasn't changed one bit. And so that's one end of the spectrum. This is another end of the spectrum. Here's a disease that showed up like this. And despite every known method of management, including radiation, ultimately enucleation, and all of the things that we could possibly do to change the course of events, this is what happened. Now, she was a lovely woman, by the way, and wouldn't mind if we showed her face. She was just that kind of woman. So there's a scheme, there's a whole spectrum of this disease that we're dealing with. And so even though we can be general in our approach to management and in terms of our data collection, we have to remember that every tumor in every patient is different in one way or another. So the diagnosis, 30% of the patients have pseudomelanoma, at least in our institution, so that we are looking at maybe 2/3 with real disease that we have to do something about. The rest of it we can observe or watch or send on. And 30% of UV melanoma patients are asymptomatic, and keep that in mind too. So the usual suspects are rounded up when you're looking at pseudomelanoma with hemorrhagic disciform disease, with congenital hypertrophy, pigment epithelium, with melanocytoma, which was very eloquently discussed earlier today. Sometimes we have multiple melanocytic lesions in the back of the eye in this case, and then occasionally you have to look at the other eye because bilateral melanoma can occur, even though it's extremely rare. Our greatest problems, or one of them, has to do with amelanotic disease in the back of the eye, and we have to go through kind of a differential diagnosis when we see this, unless it's quite obvious for other reasons. So that choroidal hemangioma may be one of the commoner. Granulomas, scleral calcification, osseous chorostomas we discussed this morning too, and intraocular lymphoma are things that we have to think about. We even get medullated nerve fibers coming to us from time to time, and for instance, for people that don't see a lot of ophthalmology. The choroidal hemangioma sometimes is difficult to see. It's a pink-orange look in the back of the eye, and it can be missed quite easily in a normal ophthalmoscopic examination, especially if it's flat. So that we have ways of trying to determine whether this is a treatable disease or not, and usually has high internal reflectivity. It's orange-pink, and it tends to blend with the fundus. The amelanotic features of this issue are very common to us all. But we have to be kind of careful in terms of suggesting diagnoses quickly. We know that in deposits, whether they be from breast or from lung, are associated often with systemic involvement, and that makes the diagnosis easier. But we also know that 15 to 20% of the time, this disease comes in just in the eye alone. In other words, this is the indicator that we should start looking around. And in fact, about 10% of some of these cases, we never find a primary. If we see multiple deposits in the back of the eye, that's a help. And if we see deposits in both eyes, that's a help. Occasionally, we do have to look further, though. In this case, we had to look around and ask history, and finally noted that this was an extranodal carcinoma with probably a primary in the testis. So this can be quite variable in terms of the systemic review required. Orange metastatic deposits, if you see this, they may be orange looking or they may be amelanotic or rather beige looking, and certainly think of the triad of renal cell carcinoma, carcinoid disease, and thyroid carcinoma, and neuroendocrine disease of different sorts. The reason that we want to be careful with carcinoid is it has a very good prognosis. We can see patients living for 20 and 25 years with this problem, so that it's important to look around and make sure that we make that diagnosis. We can treat the disease quite easily these days with 20 gray in 5 fractions. We don't have to use a lot of radiation, and we get very good results. Diagnostic tools, we're not going to belabor because we all know them. I'd just like to mention that OCT is now very favorable and technologically very advanced. It still doesn't give us all the information we'd like to know. And we have to be very careful about trying to decide whether the OCT that we're looking at is really telling us what it is looking at. Certainly autofluorescence is helpful in looking at lipofuscin, and occasionally, as we talked about this morning, tumors do grow in 3 directions, and so sometimes CT and MRI are important to look at the back of the eye and the orbit. Occasionally we make the diagnosis a little late, and the cataract surgeons don't like to see this slide very much, but that sort of thing can develop, and once we get a nicely placed lens in, the disease is discovered. Often the disease is sent to us because of retinal detachment issues. And the melanoma with detachment over the melanoma can certainly look just like a rhabdomatogenous process. We're helped now by wide-angle looks. Unfortunately, with wide-angle color, we're still in the dark, as it were, because we don't have a good scheme, a good system to get the green away. The optometrists don't mind it. But for us, we'd rather have the green out of the way, and there are ways of canceling some of that, but not well. But it does give us a very nice overlook in terms of where the melanoma is and what it looks like. On the other hand, the wide-angle angiography is really quite good and gives us an idea as to tumor dimensions, et cetera, and that is very useful to us. Ultrasound is a key item for us. We live with ultrasound, both the posterior segment variety and the anterior segment variety. In this instance, this patient decided that naturopathic therapy was more of a benefit than anything else, and so that we had to live with this patient for a long time and did repetitive ultrasounds to show the tumor invading not only the eye, but also posteriorly. Just a clue or a hint, when you are doing ultrasound of tumors that are beyond the equator or anterior to the equator, not a bad idea to try and do immersion ultrasound because you're going to have a far more accurate look at measurements. You can't get vertical enough with the ultrasound transducer unless you have some form of an anterior segment approach, such as immersion in this instance. We have ways of looking at the eye in a non-FOSS situation, and we had a little bit of a look this afternoon at the wonderful work that's being done here, which I won't give it away yet. But this sort of thing is now becoming more important. This happens to be not an invasive procedure. It happens to be a multispectral fundus imaging, which can help us look for pathology that we maybe not see initially. It also helps us look for autofluorescence in this near-infrared approach from LED sources. This isn't laser, but it's LED. So it can be helpful in some ways. We talked about OCT, and this is just an example of an osseous choristoma, which does show us some level of accuracy in terms of what's going on in terms of decalcification and calcification. Tumors that pop into the front of the eye are not common. They may be 3.5 to 10% or so of all the melanomas we see. But we have to keep in mind that when we see them in the anterior segment, that chances are they're also invading the ciliary body. And the only way we can really look at that clearly is with ultrasound biomicroscopy. So just keep in mind that the tumor that you see in the iris may well be just the tip of the iceberg. In looking at these diseases with anterior segment OCT, it gives us a very nice look at the tumor as it relates to the cornea. This can be important when you resect this disease because it can stick to the corneal endothelium and leave cells behind. Ultrasound biomicroscopy, on the other hand, gives us an entire look at the tumor and shows that this tumor is just in the iris alone, not in the base of the iris and not in the ciliary body. So we use ultrasound biomicroscopy very frequently in this disease. OCT again gives us a very good look at the surface, but because of the pigment issue, ultrasound biomicroscopy gives us a better look at the underlying pigment epithelium and other structures. We can plaque anterior segment tumors, as we're all aware, and in this comparative analysis, it shows that certainly the corneal integrity can remain intact with almost all of the radioisotopes used. Even though glaucoma occurs, tumor control is excellent, and so that we happen to use radioactive iodine-125. The tumor in this instance is a little bit larger than one would like to resect, and so therefore plaque radiotherapy really is quite helpful to us, and within 6 months' time the tumor can be almost eradicated and we don't have to enter the eye. So which lesion would you treat? Well, we can have a look at all of that and come to our own ideas as to what we treat, but then those are the answers. You see that there's growth occurring in 2 of them and no growth in 2 of them, and we probably wouldn't have known that by just looking at that tumor. So is it a melanoma? And that's really the key issue for the small tumors, particularly, that come to us. What do we do with them? Well, Paul Finger has put together this handy little mnemonic. There are many mnemonics out there, and Shields have put together theirs. This is a simple one. Orange pigment or lipofuscin can be present, subretinal fluid can be present, and the thickness can be over 2 millimeters. And this seems to be pretty reasonable. However, here's an example of a tumor with lipofuscin, with serous fluid, reasonably close to the nerve, and patient didn't want treatment. This melanocytic lesion has been in place like this for 7 years now without change. On the other hand, here's a tumor that has evidence of almost chorioretinal change with pigmentation, some serous fluid, no orange pigment, and this patient was dead in 5 years. So that we have a problem in terms of defining how we're going to manage this tumor and when. Keep in mind that pretreatment tumor thickness can be deceiving. And if you wait 6 weeks in this instance, we see the change from a dome-shaped tumor into a collar button type of tumor, or collar stud mushroom-shaped tumor, which is characteristic of melanoma, and it can happen in a very short period of time. And remember, the Andy Shackett tell us that certainly he had an OR and provided images to show us that as he manipulated the eye, the collar button just came up at him. So the collar buttons can occur very, very quickly with Bruch's membrane change. So now we're down to description. It's extremely important that if we're going to look at this tumor, and besides being anecdotal about how we deal with the tumor, that we need to be all in the same ballpark in terms of what we're talking about. So standardized description is key. We've seen that in the past there have been attempts to standardize these categories with calendars, prognosis, etc. We don't use that much anymore pathologically. The COMS came along and took 12 years to tell us certain things about 3 different styles of that trial. And that was an attempt to standardize disease. It was also an attempt to actually describe disease, and still used in many ways. The retinoblastoma classification has changed 2 or 3 or 4 times, and then the rhabdomyosarcoma people have had good help with what they've done. And the COMS came along in around 1987 or so, and involved 43 centers across North America, including Montreal, of course, with Christine Corriveau in those days. The status of the COMS trials when accrual was completed looked like this. And you might notice that the patient screen were close to 9,000. It was a very large study, very well done, meticulously maintained. The small trial, medium trial, and large trials showed really very high numbers for recruitment, but unfortunately, when you look at the enrollment at the bottom, we have much lower numbers, and that was really due to the fact that you were dealing with something that was quite disfiguring, quite disheartening to remove the eye, as opposed to something that seemed to be conservative in its treatment. The criticism of the COMS, as you see here, there were many ineligibility issues. There was a wide range for the medium-sized melanoma category. Juxtapapillary tumors were not included. Ciliary body involvement was iffy in terms of whether it was 50% involved or not. And so that there were some issues that made the cohort less than general. And the time to death by treatment for the medium-sized trial, which was the important one really, was interesting in that around 6 to 7 years out, it was almost time to come out of that trial with a difference in treatment. Well, the data monitoring committee decided, no, we'll keep it in. And they hung in there, and finally, after 12 years, those 2 curves came together, and so there was no difference and no benefit in one treatment over the other. It's a lesson in terms of long-term looks, in terms of clinical trials, don't come out too early. So the universal staging system for eye cancer became very important, and the American Joint Committee on Cancer, along with the Union Internationale for Cancer Control, got together to form the OOTF, members of which are in this room. And the OOTF was to provide an anatomically based staging system, which is the TNM, which we've all grown to love and use. The thickness node metastasis staging scheme has now been a form of standard care for most of us, and it measures tumor base, lymph node involvement, presence of metastases, ciliary body involvement, and the presence of extraocular extension. There have been 2 or 3 major revisions. We are using the 7th, which was put together by mainly the European group and looked at over 7,000 cases, and it has been recently validated. The rectangular look shows that the thickness increases, the width, diameter increases, and that be correlated with ciliary body involvement or extraocular involvement, extraocular extension, and then that be converted to staging. And it's really quite helpful. Not the whole story, but it's helpful. So cancer registries enables cancer programs to determine cancer patient populations. It's one thing for a center to provide 25 cases of something. But it's another thing to be able to provide 2,500 cases of something. And the only way that can really be done quickly and reasonably is through a registry of some sort. So we've gone ahead and looked at how to do that. Well, in September of 2011, the first concept of internet-assisted, in this case biopsy-proven iris melanomas, was initiated. And Paul Finger and others were instrumental in doing that. It gave us a very good profile of iris tumors, and it was done by virtue of a registry, as it were, all biopsy proven, and occurred over a very relatively short period of time. Multi-center large databases are really more powerful in their analysis. They have to be. 10 centers with 40 patients a year provides 1,000 cases in 2.5 years. Otherwise, it's going to take a very much longer time for a single center to provide that much. The validation of the 7th edition of the AJCC was accomplished in this manner, and we looked at over 3,000 cases with the database in Toronto. Note that 46 cancer specialists from 11 countries were involved, so it was a huge collaboration. The current and possible registries that are now ongoing, UV melanoma has been completed. Retinoblastoma is now up to 4,000 eyes, and Brenda Galley and others are now analyzing that figure. That means 2,000 patients. Conjunctival melanoma is active. Vitreoretinal lymphoma is active. Ocular adnexal lymphoma, spearheaded by Sarah Copeland and others, is also active. So that it's the sort of disease that is your bottom right, which is intraocular lymphoma, which is extremely rare. We don't know very much about this disease, and we need to. The only way to find out is to put a lot of cases together rather quickly and look at it. So which melanoma is fatal? Well, we're going to hear more about fatality from Arun in a little while. But we just have to keep in mind that this patient was alive in 10 years, and deceased after 5 years, et cetera, et cetera. We don't have any idea by looking at this tumor without help. Well, how can we get help? The prognosis for UV melanoma depends on size, it depends on location, it depends on the presence of extrascleral extension. Those are basic. Additionally, we have cell type and genetic signature, mitotic count, et cetera, which all help us in our review of that particular tumor. In 1996, Pressure and Bornfeld let everybody know that the loss of a chromosome in chromosome 3 was made life very difficult for people with this tumor. Survival was much worse. There were many ways of measuring it. More recently, MLPA, or multiplex ligation-dependent probe amplification, is something that we use in Toronto and is used really in a number of areas now. We've looked at over 100, and we find it very helpful. The risk was associated with the fact that it's monosomy or disomy, as you all know. There were limitations, and there still are limitations. Gene expression profiling is the other method. It has to do with RNA evaluation, which we all know about too, and the class 1 and class 2 were devised certainly with the help of Bill Harbour and others. So the emerging prognostic factors, as far as we're concerned now, is that monosomy 3 plus gain in AQ predicts the shortest survival, partial monosomy or gain in AQ alone, intermediate, and disomy predicts longest survival. Gene expression profiling, again, shows us class 1A, class 1B, and class 2, as you see. BAP1, or the breast cancer-associated protein, which we've heard briefly about, the mutation in chromosome 3 is associated with high risk, and ELF1AX and SF3B1 mutations may predict a lower risk, and this is also being validated and looked at. GNAQ and GNA11 mutations seem to be initiating events early on. This is all being looked at in various ways by various centers and will require validation as time goes on to see if it really is so. The fine needle aspiration biopsy is a relatively easy process. Sclera is marked as one would go in and do a plaque. Dummy plaque's placed and the sutures are placed. A 27 gauge needle we happen to use, and this dig and drill situation is important to try and get maximal sample, and then a relatively slow release, and 3 to 4 passes are probably reasonable to try and avoid some of the pitfalls. So once we differentiated these tumors, how does this impact treatment, surveillance, and survival? Well, as an example, about 7 years ago, this little girl came to us who was just under 5 years of age. And as you know, UV melanoma is a 60-year-old median age group tumor. She had this melanocytic process in the left eye, which was juxtapapillary. It certainly looked like a melanoma. And unfortunately, or fortunately, depending on how you look at it, the parents really wanted an enucleation. They didn't want to keep coming back and worrying about whether or not this child was going to have to be seen again and again, and then when that tumor would be a problem. So the enucleation was accomplished. Pathology showed us that the S100, MART1, and HMB45, very straightforward evaluations, looked positive. And she had 90% epithelioid cells, which is high, because most of the time epithelioid cells might be in the region of 60 to 70%, but not 90%. The genomics showed us that chromosome 3 and chromosome 8, chromosome 6q were not detected. And the GEP demonstrated class 1 category, and that's it at the bottom, indicating that probably this child's prognosis was going to be very good. And she's now 7 years out, and in fact, very healthy, and has written a book about it all. And we just had a look at the under 18 melanomas, by the way, and that's been recently published and has shown us that there is a better prognosis in that age group as compared to the 18 to 24 age group. So melanoma can occur in the young age. So molecular genetics and cytology, they're helpful. It's not the whole answer, but they're helpful. And their advantages are, as you see here, it definitely guides entry into clinical trials, which is important, and it guides surveillance policies as well. And their disadvantages are real. In other words, there's a sampling error problem, a laboratory error problem, tumor heterogeneity, crescendo malignancy can produce discordant behavior, which is an issue as well. So one hesitates to rely on this and to provide that information without caveats to patients. So the treatment for UV melanoma is, as you see, it runs the course of whatever is available and whatever is used at the institution. They're all successful. We can manage local treatment really quite well. This little resection is quite possible and quite easily done. Plaque radiotherapy now, very common with radioactive iodine-125 and ruthenium across the pond. And stereotactic therapy with LINAC procedures we've talked about. The tumor itself can go away within a 6-month period and look burned out. So this is essentially local control. Sometimes we still have to resort to enucleation. But this disease, we still don't have a silver bullet for. And this is obviously what we've been hearing over the last 2 discussions. How are we going to make a difference here? Well, which lesion again would you treat? Again, we need help, and we need a little more help than we have. Our future directions, we standardize tumor description, which is key. The common language is essential. We build and maintain cancer registries, and they should be international, they should be multi-center. And then we encourage and support and test novel therapies. And the novel therapies need to be based on evidence. And the way to look at novel therapies are, again, with a registry. Put a lot of cases together, not just 2 or 3 or 4. So the current phase in 3 trials that are ongoing involve immunotherapy, monoclonal antibody production, and MEK inhibition, as we've heard too. Well, are we winning? Well, we need a few more goals before we're there. And I'd just like, before we stop, to look at Ocular Oncology Service that has certainly supported me over the years, and we'll see some of those people here. And certainly the fellowship participation has been enormous. We've passed through over 30 people in the last several years, and again, some of those people are in this room as we speak. Thank you. It's been a pleasure to be here once again, and your biopsy meeting is incredible so far. It's very, very exciting. I don't think I'll ever become a member. I don't think Miguel has that in his mind. I haven't come up with enough money yet.
Thank you
Possibly.
very much for this
But thank you very much.
great lecture. And